Medurstand Understanding Medicine.
I'm Professor Azizur Rahman, and in the series of our lectures on hypertension, today we're going to talk about secondary and resistant hypertension. These are two agenda items. They are covered in one lecture because there is often an overlap. Because patients with the secondary hypertension are likely to be a resistant hypertension, patient with the resistant hypertension also. And those patients who have a resistant hypertension, and if you probe in more detail, then you are likely to find the secondary hypertension. So that is why these two topics are covered in one lecture. Uh, First takes this secondary hypertension. We know that mostly hypertension, we do not know the cause. Of course, there is one, there has to be one. There are many possibilities, many speculations. I have covered that in my earlier talk on essential hypertension. Here we are going to talk about the secondary hypertension, and we will call some hypertension as secondary hypertension when we can identify a clear-cut cause which can be responsible for hypertension. Now, in my earlier lecture titled as Diagnosis and Initial Evaluation, every patient with the new diagnosis has to undergo a detailed evaluation, and there are multiple purposes of these evaluation. But one of them was this finding if this patient could be a case of secondary hypertension. So I think those who are interested in this more detail, they can refer back to another lecture called Diagnosis and Initial Evaluation of Hypertension. But today we'll take up this one. As a rule, 90%, I think maybe 90 to, depending upon how thoroughly you investigate, and are you practicing in community, or you practicing in a specialized center of hypertension, or you are practicing in a research center. So I think you would have variable numbers. But if you are practicing in community like I am, then I think 90% of the patient with hypertension would fall in this essential hypertension. The primary hypertension, also called essential hypertension, you could call idiopathic arterial hypertension, and only 10% or less, maybe I think 5 to 10% would have secondary hypertension. So I think you need to know these stats are very, very useful. Before discussing it further, we need to have some idea how frequently we're going to see these secondary hypertension. So only in a maybe 5 to 10% of the patient with hypertension if you are practicing in a community. Now, it is a small number, but it is an extremely important number. Why? Because here hypertension is potentially curable. Whenever we diagnose hypertension, we are talking about lifelong medication and lifelong follow-up. But there is an opportunity of curing the disease. In hypertension, we cannot cure, but in secondary hypertension, there is a possibility that we can cure it. So I think that is one reason that this group is important. The second, even more important, is that if we treat their blood pressure, somebody is suffering from, for example, coarctation of aorta, and we just treat his blood pressure, then we are actually overlooking the actual underlying disease. So we are just treating one of the manifestation of the disease, not the disease as a whole. So because of these two things, we need to identify this small percentage. Now, this might take a lot of resources to identify the small percentage of the patients. So in the initial evaluation, based on symptoms, signs, and initially laboratory workup, which we do in every patient, so we identify those patients who might have secondary hypertension, and then we go for those specialized tests which are required to confirm that diagnosis. So that is the approach. So we don't want to miss these rare cases, and we do not want every patient to undergo these expensive tests. So on the basis of initial evaluation, we identify which patient needs to undergo these tests and which patient can be offered cured and needs more than just treatment of hypertension. Now, when to suspect secondary hypertension? I think there are a number of situations. One is based on symptoms. Somebody with hypertension, we do not expect too many symptoms. Somebody may just have headache and maybe little anxiety symptom, but if there has been some changes in the weight, both weight gain or weight loss, menstrual irregularities in women, edema formation, or the muscle weakness, that could, I think, alert you to a possible secondary hypertension. And then some signs, lot of variation in blood pressure, and blood pressure which is different in upper limbs as compared to lower limbs, then disparity of pulse and BP readings in limbs, and then renal bruit. Now if you put your stethoscope on the kidneys, and if you hear a systolic murmur, and that could indicate renal artery stenosis. And if you do the same on the lower part of the sternum on the back, you could hear a bruit arising from coarctation of aorta. Then refractoriness, that means of course any patient with essential hypertension may not respond adequately to the medication. There are some cases who are resistant cases, but if somebody is not showing adequate response to the treatment, and especially the patient is on multiple drugs, and especially if you know the patient is actually taking medicine, and in other words, the hypertension is refractory to the medication, that is another situation you should consider secondary hypertension, because secondary hypertension is more likely to be refractory to the treatment as compared to essential hypertension. Then specific lab abnormalities in the initial evaluation, hypokalemia, albuminuria. Now, I recently saw a patient who had hypertension for the last, this is actually a real story, somebody who had hypertension for the last 25 years, and he had hypokalemia documented. I just went through his file, and he had multiple readings of hypokalemia, believe you me, and he was just being treated as essential hypertension, and he was not on any diuretic which could explain hypokalemia. I investigated him, and he actually was having an adrenal mass, which he just had the surgery, and I hope now I will be able to reduce his blood pressure medication. And albuminuria would indicate toward the kidney disease. So these are some of the situations where you could suspect secondary hypertension. Pathogenesis of secondary hypertension, actually it depends on which condition you are talking about. Every condition has its own mechanism. So of course we will not be able to discuss every detail, but renal vascular disease would cause renal ischemia. Renal parenchymal disease would cause increased production of renin. This would also cause increased production of renin. And then different endocrine, few would produce a lot of catecholamines, and thyroid will also produce thyroxine, which is blood pressure, which can increase blood pressure. Then pituitary can produce growth hormone, which has a positive effect on blood pressure. It can increase blood pressure. Coarctation of aorta will of course lead to increased blood pressure in the upper limbs, because blood pressure is not going downward. But I think the major factor in the pathogenesis of coarctation of aorta is actually renal ischemia, because blood is not going to the kidneys, and kidneys are ischemic, and then it is producing renin, and then angiotensin 1, angiotensin 2, then aldosterone, and that mechanism will be activated. Then obstructive sleep apnea, and this is another new, I think we identified this, we recognize obstructive sleep apnea as one of the causes of secondary hypertension. You could call it as exacerbator, but this can be called a secondary hypertension. Then certain medication, and every thing has a different pathogenesis. So every case is unique, not just normal, not just like normal essential hypertension. Uh, Main causes of secondary hypertension, they relate to kidneys, renal, or adrenals, or other endocrine systems, and then vascular, and then miscellaneous. So I think very briefly I'll just mention some of the causes. In kidney, any renal vascular disease, renal artery stenosis, which can occur in younger patients, or even atherosclerotic renal artery stenosis, which can occur in elderly people, or any renal vascular disease in the form of angiitis or autoimmune diseases, SLE and stuff like that. They can cause inflammation of glomeruli. Then renal parenchymal disease, any disease which causes the disease in the renal parenchyma. Again, all autoimmune diseases, they fall in this group. And polycystic kidney disease. This is an inherited disease where one has multiple, almost numerous cysts on both kidneys, and these patients, they have some genetic abnormalities. So I think any kidney disease can cause actually, or can be associated with secondary hypertension. So we need to, whenever we consider secondary hypertension, first of all we need to focus on kidney. The second organ is adrenal. In adrenal, there could be hyperaldosteronism, and this is a small tumor which produces aldosterone. And this tumor may be so small that you may not be able to pick up on routine imaging. And the only way to pick up is when you suspect this condition and you go for the further test. Adrenal adenoma may be an incidentally discovered tumor, or those patients who have hypokalemia, they may have adrenal adenoma. They can cause Cushing syndrome, and then pheochromocytoma, a tumor arising from the adrenal medulla. And I have actually a separate lecture on this. So those who are interested, they can attend that. They can watch that video. Then we have other, practically I think all endocrine disorders can be linked with hypertension: acromegaly and hyperthyroidism, hypothyroidism, and hyperparathyroidism. They can all be linked with hypertension. Hyperthyroidism typically causes systolic hypertension. Hypothyroidism causes diastolic hypertension. But of course, you have to suspect on the basis of other clinical features and then do the necessary investigation. Hyperparathyroidism causes hypertension because of hypercalcemia. Then vascular causes, there are two main conditions. One is the coarctation of aorta. Renal artery stenosis may also be counted here, but I have counted that here. But I think renal artery stenosis may be also be counted as vascular causes. Then some miscellaneous, there are actually long lists. I will not be able to go through the entire list. Obstructive sleep apnea can be counted here. Now let's see how we investigate them. I think it's very simple. Let's take the renal first. And a renal function test, that means serum creatinine should be done. And urinalysis is extremely important. In normal people with hypertension, uncomplicated hypertension, we expect urine analysis to be normal, no sediments. But if you see albumin, if you see protein, if you see RBCs, if you see WBCs cast and hyaline cast, that definitely indicates that there is probably a renal etiology, renal parenchymal disease, or renal vascular disease. Abdominal ultrasound is very useful. In renal artery stenosis, you could see the disparity between two kidneys, especially in the children, a younger group, because the stenotic kidney would not grow in size and the other kidney would grow out of proportion. So there would be significant disparity in the kidney size. Even normal people could have some disparity, but if there is significant disparity in a hypertensive person who is not responding well to the treatment, this could indicate renal artery stenosis. And you could also do renal artery duplex scan for the confirmation of renal artery stenosis. Uh, then the adrenal, I think if you suspect adrenal etiology, serum electrolytes should be done because adrenals, they through mineralocorticoid and glucocorticoid, they regulate our sodium, potassium, chloride, and bicarb. There is there may be some abnormality. Like for example, hypokalemia is one factor which could raise the suspicion of adrenal etiology of hypertension. In hyperaldosteronism as well as in Cushing syndrome. And both of them, there could be hypokalemia. But you must make sure the patient is not on diuretic. If patient is on diuretic, that could be one explanation for hypokalemia. Then these patients may have acid-base abnormalities also indicated by bicarb level. In Cushing syndrome, we may have metabolic alkalosis and bicarb level may be elevated. Serum aldosterone level should be done and plasma renin activity may also be measured. Now, of course, these are not routine tests in our country, but in secondary hypertension, when we suspect adrenal disease, we need to do these tests. I think my understanding is that patients should be off any antihypertensive when you do these tests because many drugs, they alter our renin activity, they alter aldosterone level. So my understanding is that patients should be off any antihypertensive medication when you measure these hormones. And then methanephrin can be measured when we suspect pheochromocytoma. Previously, we used to do urinary VMA and urinary methanephrin, but now serum methanephrin is available. But this would be best done if we do the sub test when patient is going through a hypertensive episode. Then adrenal imaging in the form of ultrasound, in the form of CT, in the form of MRI. I think adrenal imaging will be definitely very useful. And ultimate would be a adrenal venous sampling, which is not available in our country. Now, other endocrine, since this is a big group, I think I will not be able to discuss every detail. Depending upon whatever you suspect hyperparathyroidism or you suspect hypothyroidism, you do that investigation accordingly. Then miscellaneous is, no, sorry, I think vascular abnormalities. Coarctation of aorta is an important condition. BP, ideally, every newly diagnosed patient should have their BP measured both in upper limbs and lower limbs in at least the first evaluation. In a normal person and a patient with essential hypertension, the blood pressure in the lower limbs, if taken with the proper size cuff, should be slightly higher than the blood pressure in the upper limbs. So blood pressure in the lower limbs is usually slightly higher than that in the upper limbs. But if blood pressure in the lower limbs is lower than the upper limb, then that very strongly indicates the possibility of coarctation. Echocardiography can demonstrate coarctation, but final test for this would be aortography. Aortography would not only offer that final diagnosis, but also allow the placement of stent, which is the treatment of coarctation of aorta. Then comes this miscellaneous, the obstructive sleep apnea. This diagnosis may be obvious on history. If you ask a patient about this episodes of apnea, patient certainly wakes up at night with sudden feeling of suffocation and sits up and then feel better. Or patient snores a lot, and when you see the patient, you can see that the patient is overweight, especially his neck is very thick and short. The patient's spouse will be able to tell you the history, but I think these patients should formally have the sleep studies. Sleep studies will confirm that the actual cause of hypertension will actually confirm that these patients do have apneic spells, and then they would have the appropriate treatment. You might work on their weight, and this bariatric surgery is very effective in relieving sleep apnea. Other measures to uh, reduce weight, that might also work, but sometimes they have given that uh, uh, BiPAP machines, and which they have to wear to keep their ventilation going at night. So we have done with one component of today's lecture, that is secondary hypertension. I think this one is very brief. Now we take up the second one, resistant hypertension. What is a resistant hypertension? Let me first, it's an arbitrarily defined condition. If somebody is on adequate doses of three different drugs. Now they have to be in the adequate. And what is adequate? Adequate is actually at least 50% of the maximum recommended. In case of amlodipine, if the maximum recommended is 20 milligrams, so adequate would be more than 10. In case of valsartan, if the maximum recommended is 640, then 320 would be adequate minimum. Hydrochlorothiazide, if the maximum recommended dose is 50 milligram, then 25 milligram will constitute adequate. So if and not only three drugs, and one of them must be a diuretic. So this is the definition. Patient is on triple drug combination, all doses adequate, and one of them is hydrochlorothiazide. And if then patient is not on goal, that would be called resistant hypertension, and goal is minimum 140/90. In my earlier lecture, I defined different goals for different populations, but here we are just talking about general goal, that is 140/90, and less than that. If blood pressure is above that, despite this triple drug combination in adequate doses, one of them being diuretic, then patient is classified as having resistant hypertension. First of all, of course, you need to ensure that patient is on adequate doses, and then you must make sure, this is perhaps the most important, you must make sure that patient is actually taking medicine. Patient is adherent to medication. Just asking that you are taking medicine, not taking, is not enough. You need to use different techniques. You need to ask the patient, the attendant, check their medicine, check their prescriptions, and I think you use the various techniques to make sure that patient is actually taking medicine. Of course, you do not want make patient feel bad about it, but you don't want to be act like a police investigator, but you ask question to make sure that patient is actually taking medication. If patient is not taking medication, then further workup for resistant hypertension, further medication for resistant hypertension is not needed. Then you need to improve or need to work on the adherence issue. Then you need to see if there are any interfering factor in the form of concomitant medication. Patient is taking non-steroidal anti-inflammatory drug. Patient is taking steroids. Patient is taking contraceptive drugs. Patient is taking some other drugs, maybe for good reason. Cyclosporin, for example, is known to cause hypertension. So you just need to examine if patient is taking any other drug which could be interfering with the blood pressure lowering medication, and if possible you would like to withdraw, or if there is another condition like smoking, like obesity, I think you need to address that also. Then if it patient is truly you don't find any problem here, and patient is truly a case of a resistant hypertension, then we add the last class of drug like mineralocorticoid receptor antagonist, like spironolactone or eplerenone. And beta blocker may also be used, alpha blocker may be used, and then hydralazine may be used, and these patients may also be offered some device therapy like renal vein denervation or baroreceptor modulation. I think all these would be possible only in specialized centers. So I think we would like to refer these patients to specialized hypertensive centers. As I said, adherence is a major issue, and we must do whatever we can to improve adherence. Now, you have to be, I think, a human first, doctor later, to address this issue. Address patient's concern in an empathetic way, and then maybe you can improve adherence. What are the factors which can determine adherence? For example, health education. Now, patient need to know why he has to take medication for something which is not giving him or her any problem. So I think health education is extremely important. We need to give an account of possible complication, possible benefits of medication, and comparing them with minimal cost and minimal side effects. Then pill burden. Uh, Studies have shown that lesser number of pills patient has to take every day, more chances that patient will actually take. Remember, if you're treating somebody for hypertension, that patient may be taking many of the drugs for other conditions also. So I think we should try to reduce pill burden. And in my one of the lectures I mentioned that European Society of Cardiology and Hypertension, they have given the recommendation that we should always start with a 2-drug pill, because most patients they need 2 drug so anyway. Administration and monitoring by family members to improve compliance, and I think if somebody else monitors that the patient is actually taking medicine, patient will feel important also. The patient will feel as if he or she is being cared, and it will also make sure that medication has been given. Then cost issue. In our country, most patients, they have to pay from their own pocket. So I think cost is a major consideration. If there is a drug which is very expensive, it may be great otherwise, but if patient cannot afford, it is no good. So I think we must consider patient affordability, and if patient can afford, only then we should consider more expensive drugs. Then side effects. All medicine they have side effects. If somebody comes to you and complain of side effects, don't feel offended. Medicines do have side effects, and address those side effects. Maybe by reducing the dosage, maybe by making some other combination, maybe changing the medication, maybe just reassuring the patient that this little side effect will go away with time. So I think these issues should be addressed. So I think this is toward the end. This is the end of this short presentation on resistant hypertension and secondary hypertension. I hope I was able to give you some insight into this topic, and I really look forward to see you in my next presentation. And this is Professor Azizur Rahman from Medurstand. Thank you for watching this video.